Welcome everyone. In my PhD studies, I would like to focus on improving postoperative outcomes after cardiac and vascular surgery. My name is Nikolett. I'm a PhD student and a specialist in anesthesia and critical care. I work at the Heart and Vascular Center at the Semmelweis University. My vision is for science to prevail over routine, and for that I would like to implement standardized perioperative protocols in cardiovascular anesthesia to minimize postoperative complications. These are my specific goals. In my first project, which is meta-analysis, I will focus on cardiac surgery, and the second project will be a randomized clinical trial where we will focus on vascular surgery. So my first project is investigating the predictive value of urinary biomarkers in cardiac surgery-related acute kidney injury. Acute kidney injury is a very common complication after cardiac surgery. Its early recognition is essential because specific treatment options are not available, only the renal replacement therapy, which is just a supportive therapy. We know that nowadays we diagnose acute kidney injury with the KDIGO criteria. It's a diagnostic tool, but not a predictive tool. Urinary biomarkers have been widely investigated to predict the development of acute kidney injury, but their performance regarding cardiac surgery is still unknown. So our aim will be to determine the diagnostic accuracy of urinary biomarkers in cardiac surgery-related acute kidney injury. If we are able to identify high-risk patients just during the operation or in the early postoperative period, then we will be able to implement preventive measures, and we may be able to decrease the development of AKI. Our hypothesis is that urinary biomarkers can accurately predict the development of AKI, and for that we performed a meta-analysis on adults undergoing cardiac surgery, and we evaluated the performance of urinary biomarkers. This was our systematic search key, and this is our flow of selection. We ended up with 91 articles. Our main outcome measure is area under the curve. We have altogether 11 biomarkers, and today I'm going to show you performance of two of these biomarkers and the AUC of the combination of biomarkers. This is my first forest plot, which shows you the predictive value of early postoperative TIM2 and IGF-BP7 for all stages of acute kidney injury diagnosed at 48 hours after cardiac surgery. TIM2 IGF-BP7 is a stress biomarker which increases quickly after the surgical procedure. You can see that the outcome measure is AUC. The AUC value is 1 if out of 5 patients we are able to predict accurately the development of AKI in 5 patients. You can see that the predictive value of this biomarker for all stages of acute kidney injury is quite low, 0.66. It means that it's a poor predictive value and it's not to be used in clinical practice. We also prepared an analysis for this biomarker to evaluate the development of acute kidney injury, not just in 48 hours, but in 1 week. You can see, so for all acute kidney injury development, the AUC values are still poor, so it does have a poor predictive value. If we examine the same biomarker, TIM2 IGF-BP7, for severe acute kidney injuries in 1 week, then we can see that the predictive value increases to a fair predictive value level. On this following plot, this is another biomarker, liver-type fatty acid binding protein, which is an intracellular scavenger for peroxidized fatty acids. And you can see 3 subgroups, which we analyzed separately: the preoperative measurement of this biomarker, the intra and early postoperative measurement, and also the later but still early postoperative measurement of this biomarker for all acute kidney injury in 1 week. And we can see that it has, again, a fair predictive value. We also evaluated the predictive value of combination of urinary biomarkers for the development of all stages of acute kidney injury. You can see that we performed 2 subgroup analyses for the intraoperative, early postoperative, and also a bit later but still early postoperative period. And you can see that for all acute kidney injury, the combination, so any combination of the urinary biomarker gives 0.8 or 0.74 AUCs, which makes it a good predictive tool. And the AUC levels increase even further a bit if we investigate the stage 2 and stage 3 acute kidney injury after cardiac surgery. And the AUC values give us good predictive value. So the strength of our study is that it's the most comprehensive study in the evaluation of cardiac surgery related acute kidney injury biomarkers. The population is quite homogeneous in terms of it's performed on the, after the same surgical procedure. Most of it was done on cardiopulmonary bypass. It also has several limitations. It has a high heterogeneity because of the different biomarker measured time points, and also the high and low risk populations for AKI. As a conclusion, we can say that individual biomarkers may identify patients with a fair accuracy, and the combination of urinary biomarkers may provide a better reaching the good discrimination level of high-risk patients. As an implication for practice, we can say that rather combination of biomarkers can be used, and in case of individual biomarker prediction, preventive measures can be implemented because they are not harmful for the patient. So we don't, if we miss some of the patients or identify them wrongly, we still do no harm. And as an implication for research, further studies for novel biomarkers are recommended. We are still in the phase of analyzing our results. And just a few words about my second project, which will be a randomized trial about the perioperative liraglutide for optimal glucose control in open aortic aneurysm repair. So it will be a interventional study with liraglutide or placebo. And we are at the phase of preparation of the protocol. So as I said, these are my 2 studies. which we aim to finish by the end of this summer. Thank you for your attention.
Congratulations. I mean, this is really translational medicine, I would say, that you just put together the many weak evidence, pieces of evidence, I mean, and then it makes stronger, actually. And those are the combination is a good idea. Now, it is not absolutely clear to me that when you talk about combination, you are talking about only these two biomarkers or more.
No, these are all possible combinations of all possible biomarkers analyzed at the same time, I mean with the same pool, and we will do subgroup analysis for the each individual combinations of individual biomarkers, but this is the all combinations for all possible biomarkers.
Okay, thank you.
Why can these biomarkers be better than the creatinine level? Because I think they are more expensive. Or which one can be the best among these?
It's a difficult question. Which one is the best? The newest is the TIM2 IGFBP7, and it has an advantage that they developed a bedside kit, so it can be done really quickly. All the others are done by ELISA, which obviously takes more time, so rather can be used for research purposes. But ideally, these biomarker level rise quicker than the creatinine, and then we can identify patients at risk at an earlier phase, and we have 1 or 2 days to implement measures and then decrease the development of AKI.
You mentioned that you're planning a subgroup analysis on all combinations of these biomarkers.
Yes.
But how many combinations we have here?
We have 11 biomarkers, and well, I have seen at least like 20 types of combinations, and they even combine 2, 3, and 5 biomarkers. I think combining 5 biomarkers is really just for research purposes. I cannot imagine doing it in everyday practice. But yeah, there are several ones. I think we will be able to do like 2 or 3 separate because we have enough data only for that.
Yeah, so you must design the subgroup analysis cleverly because there are too many combinations.
Yeah.
Okay, thank you.